You would have heard of mention of Victorious Ladies as well as Conquering Men, and those are two support groups in cancer support services. And you're probably wondering, so what is it that those two organizations do? Well, I can tell you, we do not sit around and talk about cancer. It's not a case where it's like, so what are we talking about today? Cancer. So what's on the agenda today? Cancer. No, we talk about cancer. But seriously, it is also about support. It is about reaching out to the community. It is about our caregivers. So there's a very strong relationship with the community. And through one of our signature events called Shop Talk, we go out and we meet with members within the community, churches, and we talk about what? No, we don't. We talk about support, we talk about care, we offer testimonies and stories. And that particular event has proven to be a success. And I'm sure as we move into the new year, I'm saying new year because the year is just about over, really. We will be doing even more. So that's the short note as it relates to Victorious Ladies and Conquering Men. And you do not have to be journeying with cancer. You do not have to be a patient. You, as a caregiver, as one with a genuine interest, can also be part of. But of course, you have to join Cancer Support Services, right, Jan? Yes, be a member. The doors are always open for more. We'll turn our attention now to a presentation offered by Elizabeth Parker Harris, Hope, Helping Our People Everywhere. I have a personal story and testimony of such. When I was diagnosed some 6 years ago, yeah, time flies, John introduced me to Liz, thank you very much. And Liz was the typical godsend. I had to travel to Miami for my PET scan. Nothing at all was left out. Liz was there to offer all the advice, all the support, all the counseling, and introductions to the doctors and so on. So I can't help but stop saying thank you, Liz, and publicly acknowledging her. So let's hear more as it relates now to helping our people everywhere. Please, let's welcome her.
Well, good day. Thank you so much for that warm welcome. I'd like to start by commending the leadership team, the volunteers at Cancer Support Services for always putting such a nicely organized meeting together. And it always amazes me, like, you know, Saturday morning, and it's always a full house, right? In Miami, you couldn't try this. Some people could vouch for me. You wouldn't have this. So also thank the audience for being here. It just shows that you really care to gain the knowledge and support others in this cancer journey. So thank you again. It is a privilege to be here. I feel like I'm at home. I cannot believe, Jen, that it's been 10 years that this meeting is going. I've been here from the beginning and plan to be here as long as you like to have me here. I work with a lot of NGOs throughout Latin America and the Caribbean. But Cancer Support Services is really at the top of the list when it comes to truly breathing and living their mission statement, which is commitment to the care of persons with cancer and to bring comfort and support to the affected relatives and dependents. And honestly, they truly live that. It's been an honor for us to be able to partner with them in helping patients that are diagnosed with cancer. Whether it's newly diagnosed or recurrence, I think one of the main things that patients face when they are diagnosed is, okay, am I going to survive this? What are my treatment options? And a lot of times, what is this all gonna cost me? Or am I gonna be able to get support to get to that finish line? And I think that's where we've stepped in over the last, well, I think we've been coming here for about 13 or 14 years through our agency, HOPE. It's a patient concierge service, also patient advocacy. And that's where we partner very nicely with this organization, because we have a very nice program for the last 13 years. There's some doctors here who are very aware of our program. It's free, it's complimentary, it's virtual. And so we've been able to help patients when they send us their cases, or even doctors. Doctors sometimes, want to brainstorm a case. It may be a challenging case or something that they haven't probably seen. And so we have a nice oncology team in Miami who helps us sift through all these cases every single day. They come in from Latin America and the Caribbean every day. And within 24 to 48 hours, we're able to tell a patient, okay, if you were here in the States, we go based on NCCN guidelines, this is what the next steps would be for you. This is what your treatment would be if you were here. And what does that do for a patient? Information really empowers patients to say, okay, just like we heard earlier, cancer not necessarily have to be a death sentence anymore. So patients, once they receive that information, because at the end of the day, once they're diagnosed, they're not sleeping. So 24 to 48 hours is something that they very much appreciate, that they have the information. Now, okay, I can beat this. We've given them hope, and we've given them information to go on to their journey. And so today, I want to introduce you one of our amazing radiation oncologists who's here. Over 32 years of experience, board certified, and he's actually treated a lot of Bayesians over the last, I know we've been working together about 8 years, and so it's my honor to present to him and introduce him today on his presentation, The Prostate Cancer Journey, Dr. Martin Keisch. Thank you.
Could we pull up my slides, please? Thank you for the introduction. Thank you for the invitation. Going to talk about prostate cancer in a bit of detail, but I'm trying to use it as a model or a paradigm for treating cancer in general. We talk about integrative treatment, and that is how we are all trained. Tumor boards, which are a group meeting of all of the physicians involved with the patient's care, which would include the pathology, the radiology, the surgeons, the radiation oncologists, the medical oncologists. Oh, perfect. Thank you. Yep. Wonderful. So the point of that meeting is so that we all are discussing things up front and can come up with an integrated plan for the patient. And it really is the most important part of any cancer program. You can have a linear accelerator, and I think that that step is a huge one for the island and the people of the island. But at the end of the day, you need to have a team, not just a radiation oncologist, not just the physics staff, but the whole group. The surgeons need to embrace it. The medical oncologists need to refer. And just from a statistical point of view, I heard 1,000 cancers in 2020. Approximately 60, in the US, approximately 67% of all cancer patients will receive radiation therapy at some point in their cancer journey, whether that's initially for cure or at later stages for palliative care. And so this is a huge step for the country, and one that I applaud, and you should applaud yourselves. The best care is care at home. Absolutely. Absolutely. That's part of the integration, sleeping in your own bed after you've gotten your care. So a little bit about me. I trained many, many years ago at Mallinckrodt Institute of Radiology at Barnes Hospital in St. Louis. I have a lot of brachytherapy experience, although I don't do as much brachytherapy now as I used to. We treat GYN cancers, breast cancers, not so much prostate anymore, but still have an interest in it. Basically, all treatment types are using brachytherapy, but more is really external beam radiation, and that's what we're going to talk about for most of this lecture. So prostate cancer is a disease that most people think of as older, but that's not always true. I can tell you that in the last decade, I've seen more and more men in their 50s and early 60s with prostate cancer. And screening is critical. Screening is critical for every cancer. The earlier you catch it, the more curable it is. And this is, it sounds so obvious and so profound, but that is where all of the advantage has come in terms of cure. The best linear accelerator in the world is not going to cure a prostate cancer if the gentleman presents with a PSA of 100. So you have free screening here, and you need to do the education to get the people in. In the United States, the average PSA at diagnosis is approximately 10 or less. And in the Caribbean Basin, I know this from a recent meeting from the Jamaican Urologic Society, the average PSA is over 50. And that is huge. And what we determined at this meeting was that a lot of it had to do with preconceived notions that these men, if they were going to go for screening, they were going to get a rectal exam. Rectal exam was a barrier to having the blood test that could save their lives. And so I think that just like coming in for a pap test, a pap smear, this is the key to curing more prostate cancer. So early stage prostate cancer has a great prognosis, not a good prognosis, a great prognosis. We cure over 90% of every stage 1 and 2 prostate cancer. And those are men who are caught with a PSA under 10 and a pathology report that doesn't show a very aggressive lesion. And that's why screening is so important. As time goes on and your PSA goes up, your tumor also converts to a more aggressive form. So when we try to decide what is the appropriate treatment, it is all based on stage. If the surgeon wants to operate, they need an early stage cancer. Once you get beyond stage 2, surgery is not an option. These patients now have gotten to a place where they don't have a choice of therapy. So you've lost the opportunity to treat a patient with surgery, and at that point, their only option is to be treated with radiation therapy. In early stages, you have a choice, radiation or surgery. So how do we do radiation therapy? Well, we're using a very high, powerful radiation machine, a linear accelerator. This is measured in millions of volts of power in the beam. And we are aiming it at the tumor, and we are giving daily doses of radiation in order to kill the cancer cells while sparing the normal tissues around it. And the techniques that we use are external beam radiation therapy, brachytherapy, which is internal radiation therapy. And we use it in every stage of the disease. For a stage 1 or 2 or even stage 3 cancer, they are curative. They are treatments to the prostate only in the case of early stage cancer, treatment to the pelvic lymph nodes in addition to the prostate in later stage cancers, and sometimes when patients are taken to surgery and found to have cancer cells left behind, the treatments are given post-operatively. Sometimes we combined the radiation with hormone therapy to treat the whole body for people with very aggressive cancers, very high PSAs, microscopically scores that are in the 9 and 10 range out of a scale from 2 to 10. And then in the end, when we have diagnosed too late and the cancer comes back and is metastatic, most commonly prostate cancer goes to bone, and bone pain is a symptom of locally advanced and metastatic prostate cancer. These patients can benefit from radiation to the bony lesions to both take away their pain, strengthen the bone, and improve their quality of life. So external beam radiation therapy is traditionally given now on a linear accelerator. Protons are a very special type of radiation treatment that are only given perhaps in 20 different places in the entire United States, have some benefits in certain areas, are used in prostate cancer, although not necessarily with any real additive benefit to the patient. The treatment is given once a day, 5 days a week, over several weeks. There are shorter techniques that we use when appropriate, and it really determined how quickly we can go is determined by how small of an area we can treat. If you have a skin cancer on the tip of your nose and I'm treating something the size of a dime, I can give a single dose. If you have a skin cancer that's taking up half of your face, I have to treat you over 8 weeks because I'm treating a larger area and I need to protect the normal tissues. So again, getting back to the screening, easier to treat a small cancer, can treat in shorter periods of time because we're treating a smaller volume. And these are the types, depending on how big of an area we want to treat. 3D conformal is sort of a 20-year-old technique that's suitable for very simple things, treating a bone. But when you talk about treating the prostate, you're really talking about the second line here, intensity modulated radiation therapy. We all get tired of saying that, so we just say IMRT. And basically, you're not just aiming the beam at a very small area, but now you're controlling the gradient of the beam, the intensity of it, across the prostate in order to spare the adjacent structures, the rectum most importantly, but also the bladder, the nerves to the penis, etc. These techniques have been proven. They have enabled us to raise the dose that we give to the prostate to really roughly 25% more dose than we gave when I was a resident 32 years ago. And that is where the real advantage. Back then, we were curing about 60% of early stage prostate cancer, and now it's 90%. And that's because of the dose escalation that's enabled by doing the intensity modulated radiation therapy. And it's coupled with image guidance. It doesn't help to treat a tiny little area if you're not in the right spot. So these patients get a CAT scan on the treatment machine every day before treatment, and that's how we aim the beam. In the old days, it used to be lines on the skin, tattoo marks, etc., and you're looking at the skin and treating something that's this far inside the patient. Well, that doesn't make sense. So now we're actually looking at the prostate, looking at the bladder, looking at the rectum every day before each treatment. And this enables us to give very tiny margins. We are literally treating 3 millimeters outside the prostate when we choose to. Or if the tumor is further out, we can treat further out. But the image guidance is how we can have very tight margins and give this intense dose of radiation. Stereotactic body radiation therapy is just taking that to its extreme. We are now using very small margins, and by doing that, we have less normal organs in the radiation field, less bladder, less rectum, and we dose escalate. So instead of giving 2 units of radiation a day, we're giving 7 units of radiation a day. And instead of giving 40 treatments or 28 treatments, we're giving 5 treatments. And this obviously makes it much more convenient. A week and a half is better than 8.5 weeks, even if you live 5 miles from my office, right? And so we choose these techniques for the patient. And again, if you're not screened, you're not getting SBRT. If you're caught with a PSA that's over 10, you're not getting SBRT. If somebody does a rectal exam and can feel your cancer, you're not getting SBRT. You have to be screened to qualify for these shorter, more intense treatment courses. So the machine that I chose was a tomotherapy machine because it really does it all. I own my own center. I opened it about 12, 13 years ago. Cancer Healthcare Associates has been 19 years now. And it does all of these things. And I was speaking to the CEO of the hospital, and the machine that was chosen is an excellent machine and will serve you very well. It can do pretty much all of these techniques. And it will be good for your patients, for your population, not just for prostate cancer, but for breast cancer, for cervical cancer. It is, the machine you got is a workhorse machine that can do it all, and it was well chosen. So the first step is knowing where the cancer is. The patient gets staging tests. Every cancer needs to be staged. For breast cancer, you get a mammogram, and then you get a biopsy, and then they need to do a surgery that includes looking at the lymph nodes. For prostate cancer, things are a little simpler. The most important thing is that PSA. If your PSA is under 10, you don't need any more staging. The cancer has not spread except maybe in 1 to 3% with a PSA under 10, okay? If your PSA is higher, you need to be staged, and the standard of care is something called a PSMA test, which is barely available in the States, not available here, but it is changing the game in prostate cancer staging. But once you've gone through that, now we know where the cancer is. Do I need to treat your lymph nodes? Am I just treating your prostate? And we do a CT scan in the office to calculate the radiation dose. I personally delineate the prostate on every slice, the bladder on every slice, the rectum on every slice of that CAT scan. And then it's reconstructed three-dimensionally, and we calculate the dose based upon that. Well, it doesn't help to have this very accurate calculation if the patient's moving around. So we make a cradle for each patient to hold them in the same position so that their legs are in the same angle, et cetera. And those techniques are the preparation for the treatment. The treatment itself is 3 minutes for prostate cancer. It takes 15 minutes door to door in my office. You literally spend more time saying hello than you do getting your treatment. The side effects of this treatment are very minimal. This was not the case when I was a resident. When I was a resident and we treated prostate cancer, we were putting people on Imodium and Lamodal and tincture of opium for diarrhea constantly. I haven't had a patient with diarrhea in 20 years. That's because of this technology. So now the side effects of radiation are very few. Skin irritation shouldn't even be on this list. Urinary symptoms are about it. Fatigue, for sure. When you give people urinary symptoms, that is getting up maybe 4 or 5 times a night. You get tired after 6 or 7 weeks of that, right? But these are temporary. And in the end, the side effects are trivial, and less than 1% of people have any long-term urinary dysfunction. This is a function of the modern technology. Long-term, there are several here. Again, urinary incontinence is something that we see more with surgery. So patients who have surgery, who have cancer cells left behind, who probably shouldn't have had the surgery, should have just gone straight to radiation, but get postoperative radiation, they have a rougher time. And they can have urinary leakage because they've got scar tissue from the surgery, more scar tissue from the radiation, and they can get urinary leakage. Erectile dysfunction is occasional, much less than with surgery, and it is very delayed. It is something that if it happens to a man, happens typically 4 to 8 years after the radiation. So brachytherapy was the mainstay for many, many years for prostate cancer. I put radioactive seeds probably into 2,000 men myself. And that was because the external beam radiation really didn't work that well 20 years ago. So what we did was either put permanent seeds or temporary seeds inside the prostate and gave it the same intense dose of radiation that we're doing with the external radiation now. And it was a great technique. The problem is, if you put a seed right next to the urethra, the tube that goes from the bladder to the outside world, they get a lot of urinary symptoms, much worse. And so we've really abandoned these techniques for the large part for prostate cancer, just because the external beam techniques have gotten so much better. That is what an HDR machine looks like. It's a little robot that runs a radiation source out of the box and into the patient who's lying on the stretcher. It stays there for a couple of minutes, and then it retreats back into the machine. This is probably something you guys need here for your cervical cancer population. Cervix cancer requires brachytherapy, period. You cannot do cervix cancer treatment without brachytherapy. And this is the state-of-the-art HDR, and that's something that you should be budgeting for. We're going to skip through this. So what if I have a patient who comes in with that really high PSA, or under the microscope it looks super aggressive? Well, we need to treat the whole body, because once the cancer gets out of the prostate gland into the lymph nodes, it's sort of in the bloodstream. It's a whole body disease now. And the standard care is hormonal therapy, or really androgen deprivation therapy. You're taking testosterone away. Prostate cancer cells need testosterone to divide. If they don't have it, they don't divide, they die on their own, and you can actually cure a patient who has a few cells floating through their body by taking away their testosterone for a period of time. Depending, again, on their stage and their aggressiveness, it might be 6 months of hormones, it might be 2 years of hormones. And this is an important adjunct. And so when Liz sends me a record on a patient, the first thing I do, a prostate cancer patient, is I say, what's the PSA? How does it look under the microscope? Does this person need hormonal therapy? Because that can be done here at home. And typically we want that to start 1 to 2 months before they start their radiation. And so for intermediate to high-risk prostate cancers, this shrinks the tumor. It also protects their rest of their body. It is the worst part of the treatment. What does testosterone do for a man? Helps them have sexual function, lean body mass, keeps them from gaining weight, strengthens their bones. So all of these are negative impacts to a very important therapy. What's the key to avoiding hormonal therapy? You all know the answer. Screening, right? Screening. That's at the end of the day, and these drugs are expensive too, for you people, budget-minded people, right? They're $1,000, $2,000 an injection. And so it's a good thing for the economics of treating cancer, the screening. It's a cheap blood test. It's an expensive drug. So image-guided radiation therapy, I already alluded to. That's how we do this daily aiming of the beam. And you really shouldn't do IMRT without image guidance. And you cannot do stereotactic body radiation therapy without image guidance. And so the machine that you got does this. It's almost, I don't know that you could even buy an IMRT machine now that doesn't already have image guidance built into it. But it is really what we do. IMRT with IGRT is for almost everybody in this day and age. Adaptive radiation therapy is something that we're studying, where we're saying, well, what if the person's tumor shrinks? A lung cancer, for instance, might shrink. You can see the lung tumor, and you're looking at these daily images, and all of a sudden it used to be 5 centimeters, and now it's 3 centimeters. Well, guess what? You can take that image, recalculate the dose, treat a smaller area, have less side effects. And this is where radiation therapy is going. This is really experimental at this point. It is very complicated. As you might imagine, it makes the patient's treatment much longer, because you have to stop and say, oh, we need to adjust this, do a recalculation, and then proceed. Radiopharmaceuticals I just include here for completion. When people have widespread prostate cancer in their bone, where it's in nearly every bone, this is an injectable form of radiation that goes to those lesions and treats all of the lesions at once, and is a useful treatment technique. I'm going to show you the machine, which I'm glad I actually included these pictures, because the machine that you purchased looks a lot like this machine and function. They're pretty similar. They're not identical, but they're pretty similar. On the right, you will see a conventional radiation machine. That's what most people think of when they see a linear accelerator. That happens to be a TrueBeam from Varian. They're the people who you purchased your machine from. And on the left is the machine I use, a tomotherapy machine. Looks like a CAT scanner or an MRI scanner. And that's because it is a CAT scanner, but also a linear accelerator. And the machine that you bought has similar appearance to this. It is, the patient is on a table in a ring moving through the machine as the radiation therapy is delivered. And it enables you to attack the cancer from all different angles. So we've combined a CT scanner and a linear accelerator to do IMRT and IGRT. So here's the prostate, and I'm showing this not just to show you the, do I have a pointer? No. Maybe? So on the left is the standard anatomy of the prostate in the center, with the rectum right behind it at the bottom. And you can see how close the rectum is to the prostate. And so you need to give radiation to the prostate, plus a margin, depending on the extent of disease, and you don't want to hurt the rectum. So sometimes what we do, particularly in the case of stereotactic body radiation therapy, these very high doses, is we inject a little gel in between. And this is a procedure that can be done under local anesthetic in the office. Takes about 20 minutes. And that is a liquid that goes in. It's like epoxy. It becomes a gel when the two sides mix. And then you have a little gel in there that pushes the rectum out of the radiation beam and enables these very high doses of radiation, essentially without treating the rectum at all. That gel is bioabsorbable and 3 months later is gone. So that is another technique we do to protect the surrounding organs. And these are the actual images, which I'm gonna, I think, come over here and actually point. So this is 3 different views. Oh yeah, there's one that I can take. And this one. Perfect. Hello? Yep. So there are 3 different images of the same prostate. And here is the prostate, here's the bladder, here's the rectum. And you can see that gel inserted in between in the white. There's a little contrast material in the gel. And here from the side view, so this is sort of a cross section, here's the side view. This is the pubic bone, this is the tailbone, here's the prostate, here's the bladder, here's the rectum. And you see that white gel nicely pushing the rectum out of the way so that there's very little dose that gets to the rectal wall. And so that's called an isodose curve. That is what your patient's doses will look like with the machine that you have purchased. So that is the what I do. I design the radiation. On these slices, I'm the one who drew where is the prostate, where is the bladder, where is the rectum. I'm the one who told the machine how much radiation to give from each angle and then do the actual calculation. The physicist then comes along behind me and he checks my work to make sure that it's right. We then have machines that go into our machine that we radiate the machine before we radiate the patient. So if we say we're giving 2 units, the machine says, yep, you're given 2 units, and these machines are accurate to within 1%. So radiation therapy is probably the mainstay of treating prostate cancer beyond early stage. For early stage, it is that decision between surgery and radiation. Liz actually asked me to give some comments on the surgery for early stage prostate cancer. And it's a good technique. The cure rate is the same. So if you are stage 1 or 2, it doesn't matter which path you take, surgery versus radiation. The cure rate is still going to be that 90+%. But the path is very different. And although I am not a surgeon, I work with them daily, and I can tell you that what you're doing is so different. It's like comparing apples and oranges. And this is why the team approach and educating the patient is so important. Because in one, you're in the hospital for 1 to 2 days. You go home with a catheter for 2 weeks. You can't lift heavy things or drive probably for 4 or 5 weeks. And in the other, you never are in the hospital, but you have to come to my office every day for 15 minutes, Monday through Friday, for anywhere from 1.5 to 8.5 weeks. So the paths and what you experience are so different that teaching the patient what the options are is probably one of the biggest things that we do. So that's what I have to say about surgery. So radiation therapy cures most patients, offers help to all patients. There's rarely a patient that comes in with any stage of prostate cancer that I can't help. The modern techniques that we have really have changed this. Honestly, when I was a resident, I used to scratch my head and said, why are we treating prostate cancer at all? Everybody got surgery. Back then, surgery was the treatment of choice, but it's not the case anymore. Modern techniques have, I think, flipped that. And there are some interesting ongoing advancements that are making this even better. And I think I will stop there and see if you have any questions. Yes.
Morning. Excellent presentation. Tell me about the incidence of radiation cystitis in your patients, please.
So the question was, what is the incidence of radiation cystitis? So acutely, during treatment, there is the natural history of a person receiving standard radiation therapy is for the first 2 or 3 weeks, they feel nothing. And then somewhere in the 3rd or 4th week, they start having a little more frequency, nocturia, getting up at night, some urgency, maybe a little bit of burning, very mild. By the time they get into the 5th or 6th week, they're bothersome. There's no question. And almost everybody gets it. It's about 80%. Every once in a while you see a patient and they just don't get anything. That reaches a peak right as they're finishing. And then for the first 2 weeks after treatment, it doesn't get better. And then it's like a light switch was thrown, and every day between week 2 and 8 after treatment, it gets better. And typically by 8 weeks after treatment, 95% of the patients are back to normal. That last 5% has a variable course. Almost all of them get back to normal too, but there is about a 1 to 2% chance of altered urinary symptoms for life, usually mild. Every once in a while, 1 in 1,000, you get somebody who, whether they're just overly sensitive to radiation or they have other issues such as diabetes or a strong smoking history, both of which put you at risk for radiation complications. They might develop hemorrhagic cystitis, which is when you're bleeding from the bladder, just telling everybody. So those patients require intervention, but in this day and age, it's 1 in 1,000.
Okay, 1 in 1,000. Thank you. Sorry for those, I forgot to break it down. So some of my patients would, as Doc explained, get burning, and they see blood in the urine, and after treating them on the traditional cobalt machine, it could go up to 5 years. I guess with the neurotherapies now, it doesn't have exactly a period where we would go up to 5 years for that expectation for seeing blood in the urine. So that was the question. I think there was something else I was going to ask. The surgical intervention. I don't know about Barbados, but I know for the rest of the Caribbean, most of the times we're not doing surgery as you suggested. So we go straight to androgen deprivation. So the options were doing orchidectomies. We take out the testicles for persons who presented with really high numbers for the PSA. But again, the Leupride or the Zoladex does a fantastic job of dropping the patients and their PSAs. So again, we've moved to a lot of just hormonal therapy instead, so there's no sphincter involvement anymore. And I'm glad you spoke about the diarrhea, etc. So those are most of my patients.
Yep.
So thanks.
I have a couple of questions.
I think there's a question over here on the right.
Go ahead, sir.
You spoke about the importance of screening. What are the best screening techniques available? That's the first question.
That's the easy question, okay?
Because I know that there is something called molecular testing. So I want to know a little bit more about that. And the second question is, if a person has a PSA greater than 10, as a matter of fact, I know people with PSA much greater than 10, and they are told that they don't have prostate cancer because they've had biopsies and stuff.
What should they do?
Yes.
Sure, that's a good question.
And my final question is, normally when I go and get a PSA, I'm saying the norm is 0 to 4.0. And I am challenging that now because I have done some research, and for black people, the normal range is 0 to 2.0 or not greater than 2.6. So can you comment on those?
So those are all good questions. The PSA is clearly the gold standard of screening. And I'm going to answer, so that's number one, but I'm going to jump to number 4 about what is a normal PSA. And that value is dependent not just on your race, but also on your age. So anybody who's in their 50s should have a PSA of 0.5 or 0.8. So if you have a 50-year-old whose PSA is 2, they need a biopsy. I don't need to know anything more about them. They need a biopsy. But you have to look at everything. You have to look at their race. You have to look at their family history. It is a genetic disease, particularly in the Caribbean basin. And early stage prostate cancer isn't all good. You can have an aggressive early stage cancer. And so these screenings need to be done at a younger age for people who are higher risk. If you have 3 brothers and an uncle with prostate cancer, you should be screened at 40, not at 50. So we have all these guidelines. Oh, a PSA is normal up to 4.0. Sure, if you're a white 75-year-old with no family history, but that's not everybody. We put people into boxes, and you need to look at everybody individually. So now, we'll answer the next easiest question, the molecular testing. So there are tests. So you have a person who has a high PSA, make something up, 13. Not all of those people have prostate cancer. So there are people who have just benign enlarged prostates. And not all people who have prostate cancer need treatment. There are groups of people, older people, sicker people, who have very low-grade cancers, less aggressive cancers, that can be observed. So we have developed tests that are blood tests that look at molecular factors that can help guide us to know the probability that a gentleman with a PSA of 13 has a significant aggressive cancer. And some people choose to use that information to say, we're not going to do a biopsy in you. So you might go see a doctor, PSA is 13, you're old and sick, you have bad coronary artery disease, diabetes, you've had a stroke, and your life expectancy isn't 10 years. And they might choose not to even do the biopsy based on the molecular blood testing. And so that's how that is used currently. So then the question is, you've got a guy with a PSA of 13, and you did a biopsy, and it's benign. And now the PSA is going up because why? Do they have cancer and it's getting bigger? Or do they have inflammation in their prostate that's causing the PSA to go up? Anything that aggravates the prostate makes the PSA go up. If your PSA is 5 and I do a rectal exam on you and I check your PSA tomorrow, your PSA is going to be 7 from me touching your prostate. If you get an infection from a biopsy, you have a biopsy and you get an infection, which happens about 1 out of 100 people, your PSA might go up to 100 2 weeks later from the biopsy. So it is a great screening test, and in fact, it is the best screening test, I feel, in all of oncology, but it's not perfect. So you have to look at that patient. You say, what is the size of their prostate? Do they have a 7-centimeter gland that could explain a PSA of 13? Well, maybe you just watch that patient after that first negative biopsy. Or if they have a little 30-gram gland that can't explain a PSA of 13, that's the person that you take back and you do additional biopsies. We have a technique called saturation biopsy. So a typical biopsy is done in the office. They take 12 specimens from different areas of the gland. But a saturation biopsy, you take them to the operating room, you stick a needle in every cubic centimeter of gland, and you get 60 specimens. There's no cancer hiding from that. And then you have your answer, right? So we have these techniques that are very specific to the individual case. But nobody with a PSA of 13 shouldn't have a biopsy unless they're critically ill and aren't going to live long enough to have a problem from prostate cancer. A PSA of 13 is prostate cancer until proven otherwise. Yeah. Question over here?
Hello,
Yeah.
yes. I'm Dawn. I thank you for that very informative session. And we want to emphasize early screening. So I don't have a question, but I have 2 points about Barbados specifically. 1, early screening. Cancer Support Services is the highest provider in Barbados of PSA testing. It is offered at a discounted price of $55. Perhaps our government ministers here today can work on providing free PSA testing for men in Barbados. I know Dr. Sonia knows, she's nodding because I'm the troublemaker, yes. So the second point is that we have data from a report done by Cancer Support Services of PSA testing in Barbados that shows that we should be screening here in Barbados men starting at age 40. There's a 5-year study that supports this. So we know that starting at age 40, get tested, and look on the Cancer Support Services website for the next opportunity and go early. I think that's what you emphasize.
I would absolutely agree.
Early. $55, which we pay now, is very little for our own future.
It's not even a tank of gas. I think I went way over my time, so I should probably, one more question? Sure.
Hi, good morning. Thank you, Doctor, for your excellent presentation. It was very thorough and very informative. And yeah, it's with it, even for a person like me who don't have a medical background. My question is, my grandfather, he died of prostate cancer. And recently I had an uncle who passed away. There was suspicion of cancer, and he had an enlarged prostate. So I'm just trying to find out from you, what are some of the, because you said sometimes it's cancerous, sometimes it's not. So I'm just trying to find out exactly what would be the reasons for the prostate to enlarge. Is it something to do with could it be because of a presence of something else going on in your
Could
body?
literally just be your age.
Okay.
So as men get older, their prostates get bigger. So a normal sized prostate is about the size of a walnut. And by the time you're 75, a normal sized prostate is the size of a plum. But some men at 75 will have a prostate the size of an apple. And that is all benign. There are tissues in the prostate. Prostate is made up of two tissues. One is a gland, which is the part that becomes cancerous, and the other is muscles. And the muscles of the prostate, which are a sexual function thing, they get bigger like any muscle. And so over time, those muscles become hyperplastic, and that's the part that enlarges when you have a large, benign prostate. So it isn't just the glands, it's sort of a two-part organ. So you can have a big prostate with a high PSA and no cancer. 20, you can have a PSA of 20 and no cancer. But you probably need a biopsy. You don't look at somebody and say, you have a big prostate, your PSA is 20, you're good. No, not in my office. You're getting a biopsy.
Good morning. Just in response to the troublemaker, that's what you called yourself. I didn't call you that. But I do appreciate the challenge and the question, and I just want to confirm that PSA testing is offered for free by the government of Barbados, the Ministry of Health and Wellness, at all of our polyclinics and at the QEH. The challenge is that the uptake of it is not where we would like it to be. So I say that to all of you, encourage the men in your lives to take advantage of this free service that is offered by the government of Barbados. And of course, if they feel more comfortable doing it at Cancer Support Services as well, we have no challenge with that. Wherever the testing is being done, take advantage of it.
I want to thank you again for the time that you afforded me, and I think you've got a wonderful, wonderful program here, and thank you for inviting me.